colleagues, the distinguished fellows. Thank you very much for giving me the opportunity to join you here today. So even though it was a very late, or shall I say early arrival for me this morning, I am 100% here to give these talks. So in the first part of these lectures, I would just want to give you a somewhat general overview of what is so specific in pediatric nuclear medicine, focusing on the musculoskeletal imaging. So this is where I work. This is the University Hospital of Antwerp. And I'm very happy to say that last year we inaugurated our new exclusive pediatric wing, which was built next to the hospital. So for this series of talks, I had some inspiration, and I also had some help from my friends, in particular Gopinath Ginanathagoran from London and Frédéric Péchard from Paris, two distinguished colleagues whom I have the honor of serving on the Bone and Joint Committee of EANM. And these three reference works I can recommend full-heartedly to you if you want to dig deeper into some of the issues that have been addressed in my talks. So this is what I had put on the menu for this very early lecture, just to get things starting and going. I would like to review first with you some physiological mechanisms of bone modeling and remodeling, because that is basically the basis of what we do in nuclear medicine. We study physiology and pathophysiology. Then some general considerations on nuclear bone imaging in children, some normal patterns and common variants, that is of course crucial, and with the advent of hybrid bone imaging, SPECT-CT, PET-CT, it has become very important also for us nuclear medicine physicians to know the basic anatomy and the common variants in order to avoid misdiagnosis. And of course, radiation risk, exposure and optimization is the core business and is especially important in young children. Novel techniques, I believe PET-MR is upcoming. However, applications are still limited, and a number of pitfalls really merit mentioning, because we have come a long way, but there are still a number of challenges we have to tackle. So, first of all, I would like to highlight to you that in 2015, the year we are today, we actually celebrate very important anniversaries with respect to bone imaging. And the first anniversary is the 80th anniversary of this paper that was published in Nature by Hevesy in 1935, actually for the first time showing, even though it was in a rat model, that phosphorus metabolism is a dynamic process. So showing that bone was not static, but indeed was a remodeling organ that recycles phosphorus all the time. And the second anniversary that we are celebrating this year is the 40th anniversary of this paper of Subramanian, actually showing that NDP, which still is a workhorse in nuclear medicine bone scan imaging, was better compared to other technetium complexes. So two pivotal discoveries that we are celebrating the anniversaries of this year. So then, to kick off the physiology part, bone modeling and remodeling basically are the basis of what we see using bone scan, but both are totally different. So first, you have to understand that bone modeling, or what we call bone modeling, is for a large part an embryonic process. It shapes the skeletal elements and it results in the appropriate morphology, and basically it is there to increase the mass of bones during growth. Throughout later life, it occurs in a very low rate and is particularly required for damage repair, for instance fractures, and to adapt to changes in mechanical loading. So what is typical is that resorption and formation, which I will come back to later, are uncoupled and they occur on a separate surface. There are some disease states which can increase or modify bone modeling, such as hypoparathyroidism, renal osteodystrophy, and the use of anabolic agents. And diagonally opposed to that is what we call bone remodeling. It is in fact what keeps us going every day because it ensures tissue turnover while maintaining bone mass. So it's a mechanism that allows us to adapt to mechanical loading. It also assists us in calcium and phosphate metabolism homeostasis. And in contrast to modeling, it is coupled and balanced activity of bone resorption and formation. It tends to occur in packages along specific sites, but on the same bone surface, and that is mostly at the interface with the hematopoietic bone marrow. And then just digging a little bit deeper, because the last 10 years really have given us very good insights in how the local mediators in fact influence bone formation. And in the cartoon here, I will try to point it out. Yeah, you can see that basically for bone formation to occur, we need osteoblasts, and these osteoblasts come from the mesenchymal stem cell lineage. And in fact, it is the RUNX2 mediator that forces these stem cells into an osteoblast lineage. And then through Wnt and beta-catenin signaling, these pre-osteoblasts will mature into fully functional osteoblasts. That also means that we have identified some gene anomalies in Wnt signaling that can result in skeletal malformations such as osteoporosis and syndactyly. But what you also see is that once the osteoblast has become active, it starts making bone. It does that by synthesizing first an extracellular matrix, which we call osteoid, and it is in fact what we image using bone scan when it becomes mineralized. And then a cycle of remodeling starts. And you can also see that the fate of the osteoblast after it has accomplished its task is to become an osteocyte, to become a lining cell, or otherwise to become apoptotic. So how does bone formation actually work? Well, likewise, it's in the last 10 years that we actually come to understand the mediators that are involved during embryonic growth and skeletal maturation that in fact guide bone formation. And two mechanisms have been identified: an intramembranous bone formation and an endochondral bone formation. We knew for some time already, but now we understand why things are happening. And everything comes back to the mesenchymal progenitor pool. And then depending on the balance between Wnt and RUNX that is locally present, you either have a differentiation towards an intramembranous bone formation when there is a high Wnt-RUNX balance. And then you can see these progenitor cells will slowly start to develop in a linear fashion, forming osteoblasts that will start producing osteoid that later becomes mineralized and so on, goes on to form compact bone. In contrast, when there is a local low Wnt-RUNX ratio, what you see is that you get an endochondral bone formation, and this really means that first the cartilage is as a kind of skeleton. And then, due to the influence of Indian hedgehog, which is another important mediator of bone formation, you see that chondrocytes will become hypertrophic, and this is in fact the sign that the primary ossification center is being formed. Chondrocytes will differentiate further into osteoblasts. They will start producing osteoids. A periosteum will be formed, and we have a primary ossification center. Later during development, of course, the secondary ossification centers will start at the physis. And that brings us beautifully back to what we do every day, because really, when we do bone scan, we are looking at, in fact, the formation of new bone. We see how it very well correlates in children, the scintigraphy with the anatomy, with the histology, and that is why it is important to understand how these mechanisms work. So bone remodeling, on the other hand, is cyclical, as I told you, and it's a set of highly regulated steps that we have. It's a repair mechanism, so we can replace damaged old bone, and we can maintain our skeletal integrity. Activation is serial, and regulation, it occurs on many levels, but it's largely paracrine. due to the mediators that both osteoclasts and osteoblasts will respond to. And just some interesting numbers to raise your interest in bone remodeling. Did you know that the rate of turnover of the whole skeleton is approximately 10% per year? And if you look at an individual site, it can take up to 2 to 5 years for successive remodeling events to occur. And the lifespan of a remodeling unit is approximately 2 to 8 months. And what is interesting is that the turnover rate is 10 times higher in trabecular bone, for example, lumbar vertebra, compared to cortical bone, such as the femur. So I told you about osteoblasts and how they make bone. Of course, we also need the osteoclasts, because those are the cells that remove bone. And in contrast to the osteoblasts, osteoclasts will derive from the hematopoietic stem cell, this cartoon. And recently, let's say, at the end of the 1990s, a very important mediator was discovered, which is the rank ligand, or the receptor activator of the nuclear factor kappa B ligand. And it was really the missing link in bone physiology that we knew existed, however we failed to identify it. Rankle was known as osteoclast differentiation factor and probably 12 other names, but Rankle, when it was first discovered and described, was the name that stuck. So basically what happens if you have a hematopoietic stem cell and you culture it with macrophage CSF, colony stimulating factor, and Rankle, what you see is that you can drive these cells into an osteoclast lineage. And with the activation or the binding of Rankle to the surface of the pre-osteoclast, you get a mature osteoclast. And mature osteoclasts are very special cells because they can resolve bone. They do so by secreting protons, so acid, and also enzymes, cathepsin K, which can dissolve the matrix. Now, one final thing I wish to show you is osteoprotegerine. Why is this important? Well, you can understand that Rankle is a very dangerous molecule. If you have too much of this, you will digest your own bone. So we need not only to have something to put on the gas, but we also need a brake. And OPG is really the brake of the Rankle system, because it is in fact a decoy receptor that will also bind to Rankle and activate it before it can bind to the Rankle receptor on the pre-osteoclast. So putting this all together, a cartoon can be very useful for this. If we have a microfracture that develops in bone, we will get an activation of bone resorption through the maturation of osteoclasts. Once the bone defect is resorbed, you will get a shift in cell population with osteoblasts that come to this location. They will create new bone, and in fact, they will have fixed the defect that was present. And this continues in cycles, as I've just shown you. Okay, so far, some physiological considerations. So, pediatric bone imaging is a frequent procedure in pediatric nuclear medicine. However, I do acknowledge that, at least in the environment I work in, there has been a very important shift towards ultrasound and MRI for many conditions in the past few years. Nevertheless, we should always be convinced of our own strengths, and that is that we have a very high sensitivity for detecting pathological processes that are multifocal or involve the entire skeletal system. Also, many of our studies tend to have a very high negative predictive value, so that can be important to rule out underlying disease. And this is just, in my opinion, a non-limitative list of the indications for skeletal scintigraphy in children. So, having said that, pediatric nuclear medicine can be challenging. It is useful if you have educated pediatric technologists. However, in smaller departments, that is not always feasible. We all know the bag of tricks that we need to distract youngsters. Books, videos, music can all help. Luckily, I can say that sedation usually is not required for the studies we do, often in contrast to MRI. Even for SPECT-CT, we don't routinely use sedation. It is only used in routine for children who are mentally handicapped or otherwise unable to cooperate. If you do, of course, use sedation, then the appropriate monitoring should be available. And various immobilization techniques can be useful, for example, as other tools. Also, when you're talking about pediatric nuclear medicine, resolution and positioning really are key. And luckily, the low energy, high resolution collimators are very well available. And technology is helping us as well. For instance, the resolution recovery software that is now available on modern cameras can be a real boost, because basically what it does, it models the blurring of the image by the collimator as the distance from the detector increases. So if you can measure, or if the camera can measure the distance of the patient to the collimator, then you can use or implement this model to correct for that distance. So you either get a better resolution with the same administered activity, or you get an equal resolution with a lower activity. So how much do you give a pediatric patient? Well, I'm very happy to say that committees of ENM have produced a wonderful document that we use almost, if not all, every day, where and I've listed some isotopes and traces that we use routinely in bone imaging. So you can very easily use this tool to calculate, based on weight and the class of isotope you're giving how much activity you should administer. And there are very useful iPhone and Android apps out there to guide you. So the two radiopharmaceuticals I would like to discuss somewhat more in depth or highlight are, of course, technetium-99 MDP and sodium fluoride. So to start with the workhorse, really, MDP, as you know, it is a bisphosphonate, and it localizes in lines between osteoid lining, marrow cavities, and the more peripheral bone. What really happens to the bisphosphonate, or labeled bisphosphonate, at the site of bone remodeling is still, I believe, a matter of some controversy. Whether the tracer really dissociates or not, we're not quite sure what happens really at that point. However, as you all know, it is cleared very rapidly from the blood, and after 24 hours you only have about 2% remaining. Nevertheless, plasma protein binding is high. It starts at about 30% and can become 100% at 24 hours. For the administered activities, this is what you find in the reference works, but of course, please use the dosage card. We do very much understand that uptake in bone is dependent on local blood flow and bone tone. So how should you prepare the patient? Well, basically the only thing you need to do is assure an adequate intake of oral fluids, and that basically is it. If the patient is in the age range to control his bladder, you should of course stimulate voiding prior to imaging, but of course that is not always under our control. Planar imaging is still routinely performed. It is the mainstay imaging, and of course three-phase imaging is the solid foundation of that, and in particular useful when you have an indication suggesting inflammation, infection, or for example an aneurysmal bone kyst, which you will see better on the flow images or blood pool images compared to late phase imaging. And illustrated on the slide, where you can see increased vascular and blood pool imaging, but in fact normal late phase imaging. So this is where the three-phase imaging is really useful, so you can distinguish inflammation from bone infection. Is there a problem? Okay. Is that better? Okay. So the next challenge, of course, is the new technologies, such as hybrid imaging, when do we use them? And if you look in the literature, what indications for SPECT-CT are, well, then the only conclusion that you can, that I can present is that we're not quite sure yet. It is still a developing modality. So you can use it to clarify SPECT abnormalities, for instance, if there is localized low back pain. But you can also do it to cover a region of pain, even if scintigraphy is normal. And this is the protocol that was published quite recently, suggesting some CT settings that may be appropriate or are appropriate for the patient population. But again, this is not yet final. I believe we will see some changes to this. Keeping in mind, of course, that if you add CT to the study, you will add radiation exposure, but I will come back to that later. So moving on to sodium fluoride, PET-CT, of course, different technique. Pharmacology is somewhat different. You have a bi-exponential clearance, and basically all the sodium fluoride that is delivered to bone is retained by bone. And you see that after 1 hour, approximately 10% remains in the blood. Uptake is follows the diffusion into the extracellular space, and binding preferentially occurs due to chemiabsorption to newly mineralized bone. In contrast to MDP, there's no protein binding, and again, for the dose or activity, I should say, I refer you to the dosage count. So the potential benefits and limitations of sodium fluoride PET-CT tend to follow that what we see in the adult population. So you can image earlier. You have a higher resolution, which is thanks to the PET technique. The tracer availability depends on where you work. Tracer availability in my country or my environment is not an issue. It is finding time on your PET-CT device to do these studies that is the issue. So unfortunately, 3-phase imaging is not so easy to do on PET-CT. We don't really have a pinhole equivalent. On the other hand, you can use oral tracer administration in children if vascular access would be an issue. You have to consider radiation exposure, even though that is somewhat relative. I will come back to that later. And likewise, the only patient preparation that is necessary is hydration. So what do I mean by the radiation exposure, which I put into brackets? Well, if you look at the equivalent effective dose that you get per megabecquerel, you see it is higher with sodium fluoride than it is for MDP. Nevertheless, technology has moved on, and especially thanks to the time-of-flight scanners, you can effectively perform sodium fluoride PET-CT in these patients using a smaller administered activity. So with all the things being equal, probably the absorbed dose can be that what you would get with a standard bone scintigraphy. You can also do it without its attenuation correction CT, even though I do not recommend it, because you lose specificity, because the things you see on the PET are then somewhat difficult to correlate with, in fact, the anatomy. Sedation, however, can be required, in particular in the younger children and toddlers. So again, if I look in literature, trying to find real indications where you should do fluoride PET-CT instead of bone scan, what struck me is that it has been used in many indications. For example, the evaluation of back pain, sports-related injuries, and evaluation of condylar hyplasia. However, when I considered these, I was not really sure whether these are really things that you could not demonstrate using MDP, so I'm not really sure how absolute these indications are. However, and I highlighted it in bold, I do believe there is a very significant role for this technique if you are looking to non-accidental injury. So bone trauma due to child abuse, just because you need the additional resolution. So that is one indication where I would suggest saying that sodium fluoride PET-CT is better than MDP. Even though you still have to do the skeletal surveys because it is a complementary diagnostic. But it is open for evolution, and it would be interesting to see how this slide will look in 5 years. So before you can, of course, go reporting pediatric skeletal scintigraphy, you have to know what is normal and what is abnormal. And that does require you to understand some physiological changes that happen throughout the very early life. For instance, ossification of the growth center. As I show you, what we see on bone scan of sodium fluoride PET-CT is in fact deposition of the tracer in newly formed osteoid that is mineralizing. So you need ossification before you can see something on bone scan. And that is important for the epiphysis, the tarsal navicular, and the patella, because they do not start ossifying immediately. You can see for the patella, it happens somewhere between 1.5 and 6 years. And for the tarsal navicular, it can take up to 5 years in boys before it becomes ossified. So an absence of uptake in these regions does not equal a vascular necrosis if you do not correlate with the age of the infant. Ossification is usually said to be completed by 25 years of age, depending on the site. You see that sternum and clavicular are the last ossification centers to be closed. Illustrated in a 1-month-old baby, you can see that there is, in fact, you cannot see, there's absent uptake, the shoulder, the wrist, the elbow, the femur, the knee, the midfoot, and the pelvis. And the tarsal navicular is also a wonderful illustration of this, because here you see the spot views of a 2-year-old, where you can not see anything at the tarsal navicular. However, if you wait with just one and come back at 3 years, you clearly see the ossification of the tarsal navicular. Likewise for the patellae, in this 2-year-old girl, you can't see them because they haven't started ossifying yet. One particular interesting pitfall is the mesosternal ossification centers, because this tends to be visible until, for instance, in this 18-year-old boy, and these kids often come in with pain, which we believe is referred to the chest, but these 3 lines you see here is in fact normal physiology. It has nothing to do with pathology. And likewise, the scapular epiphysis, I can show you, can remain, can be seen on bone scan, but it's just physiological. Another interesting pitfall is the ischiopubic synchondrosis. This is in fact a cartilaginous junction between the inferior pubic ramus and the ischium, and it ossifies between 4 and 12 years of age. So it first appears as photopenic, then it becomes a hotspot, and for a reason I don't really understand, but at the age of 8 it can become asymmetric. But again, this is normal, it's not pathology. So what you see here in this 5-year-old is you can see the photopenic defect. If you look in a 9-year-old, you can see the hotspot, but if you look in an 8-year-old, for some reason at that time it becomes asymmetric. So don't read this as pathology on the left side. So the advent of hybrid imaging really has upped the ante, as we say. It has increased the stakes, because it means that we as nuclear medicine physicians are also looking or correlating what we see as hotspots to the anatomy on CT. So that requires us to have a good understanding of what we're doing. And this really literally is a textbook case of an 11-year-old with ankle pain. And it beautifully illustrates the power of SPECT-CT in anatomical regions that are complex, because basically the planar imaging, well, you don't get any wiser by that. You can see the hotspot on SPECT, which you can now localize, but still really you don't have a clue what's going on. It's only when you do the fusion and you look at where this hotspot correlates on CT that you see the fibrous fusion between the calcaneus and the navicular. So this is in fact a tarsal coalition. And also accessory bones that are anatomical aberrations but occur quite frequently can be a cause of pathology, as illustrated in this slide. In particular, in youngsters that do intensive sports, an accessory navicular can become a source of pain. Another interesting and very common variant is an trigonum. So it produces a posterolateral pain, and that is in fact a kind of a posterior impingement syndrome. It is present in approximately 3 to 13% of the population, and you will see it's causing pain, in particular in young ballet dancers, because they tend to do a lot of extension of their foot, and it then can cause a posterior impingement. But it is not a fracture, it's in fact an accessory bone. So, moving on to radiation risk and exposure. That is in fact the dilemma we have for some time in our discipline, because we want to have a diagnostic benefit, we want to cure the patient, or at least give them a diagnosis that can lead to adequate treatment and cure. But what we do is also potentially harmful. We give young people ionizing radiation. So we have to balance these, and the tool we can use to do that is ALARA, so to give these doses that are as low as reasonably achievable. And yes, this is very important, because once every while in global news media, this will pop up. So for instance, this CNN headline stating that CT scans are linked to cancer in kids can cause quite some anxiety among parents. Nevertheless, we should also be aware of the opposite. This is a BBC headline from early 2014 stating that a boy died from an undiagnosed brain tumor because imaging was delayed, because they didn't want to do imaging to protect the child, to avoid unnecessary radiation exposure. However, that led to a very late diagnosis, and unfortunately a cure was no longer possible. So how do we balance these two conflicting principles? So first of all, we should be aware, and I believe we are aware. Nuclear medicine is very much aware of control of radiation exposure, especially in children. And if you look at some USA data from 350,000 children, you see that by the age of 18 years, these kids will have on average had 7 radiologic examinations. Now, luckily for nuclear medicine, 85% of them are X-rays and 12% are CT. You see that radionuclide imaging only represents 1% of these studies. Nevertheless, as I told you, when we start doing SPECT-CT, we are moving up to the CT part, so we are adding dose to these patients. And there, two principles compensate each other to some extent. So first of all, we scale the activity to the weight of the child, and this results in a relative lower patient dose for smaller patients compared to adults. Unfortunately for us, the risk of children to develop cancer after radiation exposure is approximately twice that of an adult. So these are two counteracting principles. And that takes us back to radiobiology, really, because what causes cancer are mutations, and these are due to double-strand DNA break. Research has shown us that they tend to increase linearly with dose, and in small animals, they reach a plateau at 3 and 5 centigrade. We also know that fractionation or reduction of the dose rate reduces the carcinogenic potential, and of course that is very important for nuclear medicine because the dose rate tends to be lower. As yet, there is no evidence in radiobiology that we can cause mutations that are then passed on to subsequent generations, and that data come from the Hiroshima and Nagasaki survivors. Also, multiple studies confirm the increasing cancer risk in humans with increasing doses of radiation, and multiple cohorts have confirmed these findings. So, what is also interesting is that following a whole body exposure to irradiation, you can see that not all tissues are equal. You can see that the bone marrow tends to react first. You have a peak in leukemia approximately 5 to 10 years after exposure. But then for the solid tumors, the other cancers, it takes up to 30 to 40 years before they become visible. And these are the general observations. Bone marrow reacts earliest, as I've shown you. Children are more susceptible than adults, in particular to leukemia, and also exposure in for the unborn child is important here. And the Chernobyl disaster has learned us that childhood cancer, thyroid cancer, is very relevant as well. Nevertheless, we also have very intriguing experimental evidence that suggests a paradoxical effect, so that low-dose radiation can in fact have a protective effect. We hypothesize this is due to the upregulation of scavenger mechanisms for free radicals, enhanced immune system response, upregulation of DNA repair mechanism, and so on. Nevertheless, we should always remain prudent, and the linear node threshold model therefore remains the most robust. So now it's time to put some numbers on this, and now it gets tricky. So we estimate that if we give a 10 millisievert exposure to a child, this will result in a 1 in 1,000 cancer risk. Okay? So not that insignificant. And this is why. This is the same 10 millisievert exposure as a function of age. And what you can clearly see is that both for the cancer incidence and the cancer mortality, how younger you are puts you at a higher risk. And what is also evident is that females have a higher risk than males. And we do believe that is because of the high sensitivity of the developing breast tissue to radiation. So let's dig into some further numbers because this is becoming important now. So what if we do a bone scan in a 10-year-old? Well, just to give you a reference, you know that the natural annual radiation exposure, according to UNSCARE, was estimated to be 2.4 millisieverts. The effective dose for a technetium MDP bone scan for a 10-year-old, and we say that he or she is 33 kilograms, is approximately 4 millisieverts. So using the same numbers, this will give a probability of potentially developing a fatal cancer in 1 in 2,500. Yet, you should also consider the baseline risk if you want to communicate this. Because this would mean that if 2,500 10-year-olds were exposed to bone scan, one additional child will develop a fatal cancer during their life, in addition to the 550 who will spontaneously develop a fatal cancer. So the attributive risk is 0.04%. However, remember, if you add CT scans, and these are data for diagnostic quality CT scans, you approximately add half a millisievert for every 10 centimeters scanned, which is of course also a function of the region, but just to keep matters simple. So from the EANM Pediatric Bone Scan Guideline, a very useful table has been published, or it contains a very useful table, in which you can see the CTDI volume coefficients for a number of tube current and tube voltage settings according to the age, so that you can see what and benchmark your own results with this table. What can also be useful to communicating this radiation risk is referring to lifetime risk of other events. So, for instance, if we go back, I can show you, to the 10-year-old receiving a bone scan, the fatal cancer risk 1 in 2,500 approximately, but you see that this is in fact or less frequent than of a lesser risk than you would have of dying from falling from stairs during your life. So it can help you to explain this risk to, for example, parents or caregivers. And to that extent, leaflets can be very useful. We have patient leaflets for many studies, but we have parent leaflets for pediatric patients. And this is basically what we put in them. So what about radiation exposure? Well, we tell parents that indeed that child will be exposed to a very small amount of radiation that is within the lower range of what is received from routine diagnostic imaging procedures that use X-rays. We add that nuclear medicine has been used on babies and children for more than 40 years with no known adverse effects from the low doses employed. You should always add, and that is because what we are committed to ensuring that your child receives the smallest radiation dose needed to obtain the desired results. We're not taking fancy pictures. Our doctors balance the medical benefits of any imaging test with the potential radiation risk, even if they are minuscule. So what can we do to do better? Dose optimization. We can lower the radiopharmaceutical activity that we administer. And for that to do, really, we need standardization. And I believe all professional societies, in particular SNM and ENM, are very focused on producing guidelines that can result in a more homogeneous use of these techniques. We should do appropriate clinical indication, utilization criteria, sequencing of studies. That can also be addressed with adequate guidelines. Technology is helping us. We can optimize imaging protocols by using, for example, dose modulation on CT. New image processing algorithms, such as iterative reconstruction, can also help us. But hardware advances, as I also already highlighted, as resolution recovery, can be very useful to these ends as well. So the advances in detectors that we have had can be twofold. First, for example, on PET, we have had the time-of-flight technology that has become available. So you can have same quality with lower injected activity. For SPECT, we have the resolution recovery algorithms, but also CT is advancing. Remember, dose modulation, so that means that the tube current is adjusted based on the scout data of the patient. And iterative reconstruction, which is kind of funny because we have been using it for 30 years in nuclear medicine, and now it's also being used in CT data reconstruction, so that's a good thing. Allows for a better quality using the same dose or same quality with lower dose. And just to give you an idea of the impact the use of iterative reconstruction can have. So 2 CTDI volumes for a spine study. This is an adult, I will admit. But you can see if you use filtered back projection, this is what the number you would get, which you can more than have, having equal image quality when you use an iterative reconstruction. So workflow can also contribute to reducing exposure. So for my local practice, this means that every appointment for a child below the age of 16 is made between physician and physician. So it's not just the secretary who arranges this, and every indication has to be agreed by us before we do the study. We always start with planar and SPECT studies first, and then when the patient is on the table, we review these results before we decide on the appropriateness of a further CT study. And only if we think it's useful will a small field of view CT be acquired. And we use the settings, as I show you, that were previously published, so 80 kV and 5 MAS. So finally, what's new, what is upcoming, what is hot? I believe PET-MR is hot. It is only because PET detector technology has evolved, and in fact the avalanche photodiode is pivotal to that, that we can now have a truly simultaneous acquisition hybrid scanner, which reduces, of course, the risk of misregistration and motion artifacts. And the benefits of MRI over CT, we all know them. We have no radiation exposure penalty. We have really exquisite tissue resolution. You can do characterization by the virtue of diffusion-weighted sequences, perfusion and spectroscopy. And of course, you can do a much better local assessment, for instance, of tumors. I'm very happy and proud to say that only last week, we inaugurated the first PET-MR scanner in Belgium, which is, I'm also very proud to tell you, a truly collaborative effort between the various university hospitals in my part of the country, so that we could afford this very expensive new machine. However, it is a technology that is still developing, so some limitations also merit attention. So the correction for photon attenuation using a mu map is challenging, even with the Dixon sequence. There can be differences in SUVs between PET-CT and PET-MR. Some anatomic regions, such as the lungs and the bones, and as musculoskeletal imaging is a focus today, that can be very tricky. It is expensive, as I told you, limitedly available. Yeah, we now have one in Belgium. I believe there are 6 to 7 in Europe. And the literature, the evidence is not yet mature, in particular the pediatric evidence, but we can also extend that to the adults. So we're not quite sure in which indications we should use this technique. And long acquisition times, which can last up to an hour, usually do require sedation in the younger patients. So what I found from data, I will show you. So a very small prospective study in 18 pediatric oncology patients, median age was 14. Results were compared to FDG-PET CT. Unfortunately for my talk today, there were only 4 musculoskeletal tumors in this series, but nevertheless, I show you the data as they are. So their major conclusion was that lesion detection was not superior to PET CT. PET-MR may miss pulmonary lesions, so a chest CT is still advised. SUVs were found to be comparable, except for lung and bone marrow, and this depended on whether they did the PET CT first or the PET-MR first. However, as we expect, there was a 73% reduction in radiation dose. So the next study was a retrospective study, and it was not exclusive to pediatric patients. As you can see, there was a very high range, a very wide range between 7 and 86 years of age, but I show it to you because it included patients with FDG-avid bone lesions, so very relevant for what we are discussing. They compared to PET CT, and they also compared to MRI sequences. They compared VIBE to turbospin echo. And the major finding was that, again, there was a similar level of lesion detection. The spin echo sequence was better than VIBE, and it was also better to CT when you wanted to delineate a lesion. However, there was no difference in calling a lesion benign or malignant. It was the same. And they did find significantly lower SUVs for bone on the MRI machine. So let's take a look at the pitfalls that we have identified so far, really showing you that this is not just the next generation PET CT, this is a different modality truly, and we need to understand it before we use it. So the majority of pitfalls are really caused by inaccurate attenuation maps, so that is where a lot of work will need to be done. And that is basically because proton density and relaxation times, which is what we look at with MRI, are not directly related to photon attenuation, which is what hampers the X-ray from, or the gamma ray from escaping the body. For example, on MR, you will see that both cortical bone and air have a very low signal. However, it's obvious to you that both have totally different attenuation characteristics. So bone segmentation is an issue. Potential solutions include atlas-based methods, but they only go so far. I mean, after complex surgery, there's no reason that you can reliably use an atlas to correct for bone. Or you can use ZTE sequence, but that's not really mature as well. For the lung, we have the same problem because there are virtually no protons in air, which then cause susceptibility artifacts. So even though the technique really is simultaneous in acquisition, misregistration can still occur, and that is what is intrinsic to organ motion, for example, in the heart and diaphragm and the liver. And MR can contribute some very unique solutions to that because we have motion-sensitive sequences. We can also do tagged MRI, radial acquisition, and so on. For MRI, you need coils, and these coils are in the field of the PET. So the question is, do they attenuate photons in a relevant way? And in fact, there is evidence, or the evidence is growing that they do. So the presence of the coils can reduce true counts up to 5%. So we probably should include that in the attenuation correction algorithm. And we can do it rather easily because we can make a CT template of the coil and include that into the reconstruction algorithm.
Professor Tim, time please.
Yes, okay. So, B0 field inhomogeneity. What that means is that the field of view for MRI is smaller than that of PET. So what you see is that you tend to overcorrect the edges, which gives you these waves. B1 field inhomogeneity. That is just due to the high power of the high field MR scanners, 3 Tesla. They can induce eddy currents and standing waves, which results in artifacts. But newer coils may be able to solve that. But then metallic implants really remain an issue. Again, because our attenuation maps will get faulty due to the susceptibility artifacts. And I will just show you. You can see here a surgical clip giving a susceptibility artifact leading to a misconstructed PET image. Again, an intravenous access device giving a large susceptibility artifact, giving an incorrect attenuation map. So what is also challenging is because these studies tend to take so long, we now see contrast going to places where we're not aware they were going. So if you image patients for up to an hour after gadolinium, you will see that the gadolinium moves to the joint space. But this is just appears to be physiological. There is no inflammation or whatsoever, so it's something you should be aware of. And the final thing I want to show you is the shine-through artifact, because it's quite unique to this modality. Briefly, you know that a positron will travel a finite distance before it annihilates. But this distance is a function, or it can be influenced by the Lorentz forces in the MRI field, in the magnetic field. And this means that the range narrows in the axial field, but it also means that it elongates in the transaxial field. So on this slide, you see the upper part, a PET-CT image, on the lower part, a PET-MR image. You can see that the axial or transaxial image on PET-CT here and PET-MR here, you can see PET-MR is much more clear, less of a blur, but what you also see it is the other way around in the other planes. But what you can see is that when a source is located in an area of low proton density, you get shine through on the opposite borders of the cavity. So this is an artifact. It's really unique to PET-MR, but it's not pathology. It's just caused by the forces going on within the magnetic field. And that's the last slide of my presentation. Thank you.